today's webinar. I'll take a 30 seconds pause for saluting our brave warriors. So I'll put the meeting on hold for 30 seconds. Thank you all. Thank you. So we'll proceed with today's agenda, and that is drugs on pediatric oncology. For today's session, I would like to introduce our program director, Dr. Vidit Kapoor. Sir is an assistant professor medical oncology, Amrita Institute of Medical Sciences, Faridabad. Thank you, sir, and over to you.
Thank you, Dr. Karan. It is yet again my privilege and honor to welcome you all for the 17th session in the continuing E-Gurukul series that we all know is an online educational initiative that fosters learning among students, residents, fellows, and practicing medical oncologists. So today's topic is drugs used in pediatric oncology. And we will hopefully we have an insightful session where we can cover basic drugs utilized in pediatric malignancies along with their mechanisms of action, their indications and side effect profiles. And guiding us through this important discussion, we have with us Dr. Reghu, who is a renowned pediatric oncologist. He's currently the senior consultant in the Department of Pediatric Hematology and Oncology at the Tata Medical Center in Kolkata. So without wasting further time, I would like to invite Dr. Reghu to take stage and moderate the session. Thank you so much.
Thank you, Dr. Vidit, for inviting me for this session. Today, we have a very interesting topic, drugs in pediatric oncology. Chemotherapy forms the backbone of practical pediatric oncology. And the use of chemotherapy drugs in pediatric oncology goes beyond mere dose adjustments. So let us learn more about it from the experts today. We have two faculties today for in today's session. The first one, Dr. Sameer Bakhshi, is a very well-known, eminent, and experienced pediatric oncologist in the country. Sir is the professor and head of the Department of Medical Oncology at AIIMS, New Delhi. I welcome you, sir, to this session. Next is Dr. Nandakumar R, Assistant Professor of Pediatric Oncology at Amla Institute of Medical Science and Research, Thrissur, Kerala. I welcome you, Dr. Nandakumar, to today's session.
Thank you, sir.
So today's session will be in two parts. The first one being a talk by Dr. Nandakumar on chemotherapeutic drugs in some of the common pediatric malignancies. This will be followed by a session led by Dr. Sameer Bakhshi. Sir will do this in a Viva Voce model, which will be very useful for the residents, I believe. So over to you, Dr. Nandakumar, for today's talk on chemotherapeutic drugs in pediatric oncology.
Yes. Good afternoon, everybody. At the outset, I'd like to thank the organizing committee for having chosen me to talk about this. I get chilblains when I'm being moderated or under the tutelage of such a great person like Dr. Sameer Bakhshi, sir. And so is Dr. Reghu, sir, who's also a senior alumnus from where I passed out. Thank you for all the attendees for joining on a Sunday afternoon. If I could proceed, I could share my screen. Yeah. So can I start? Am I audible?
Yes, sir, you are audible.
Yes, thank you. Okay. So great thanks to Dr. Karan and Dr. Vidit for having me here as well. So the topic given to me is drugs used in pediatric oncology. So I would just like to cover a few of the embryonal tumors because that is something which is very distinct from what you see in adult oncology, and a little bit of immunotherapy in BALL, which is similar to what people use in adult oncology as well. So the scheme would basically represent some of the embryonal tumors, which includes neuroblastoma, hepatoblastoma, Wilms tumor, retinoblastoma, and medulloblastoma. So I'll start with neuroblastoma because that is the most common extracranial solid tumor that we see in
So, sorry to interrupt you. Your screen is not visible. If you can share the screen.
Okay, one second. 1 second.
Yes, sir. The screen is visible. So if you can make
Okay.
it full screen.
Yes. Yeah. Okay. Okay. Sorry, I thought it was in the. Okay. So we start with
Sir,
neuroblast.
so actually the history panel is open. So if you can just turn it off at the right side.
You can
Okay.
close the history panel. Sir, please.
Yeah. Yeah.
Yes, sir. It's visible.
No. Okay. Thank you. Sorry for those inconveniences. So we'll start with neuroblastoma. Neuroblastoma, as you all know, it is the most common pediatric extracranial solid tumor. So neuro-oncology is a different specialty per se or a subspecialty in pediatric oncology. Excluding that, neuroblastoma is the most common pediatric solid tumor. And most of the times we see advanced presentations in terms of neuroblastoma, wherein the high-risk disease, which is usually 50%, is what we generally see, and it is associated with a very dismal outcome. So one of the hallmarks of neuroblastoma is the clinical heterogeneity. For example, if you say all the other diseases, when you risk stratify, we have a low risk, we have an intermediate risk, we have a high risk. So the low risk in neuroblastoma, in fact, can be spared from chemotherapy per se. You can straight away observe the child without the additive effects of chemotherapy. Whereas intermediate risk is a vast umbrella terms wherein you have different presentations, and at the same time you have different regimes. Like you can give as low as 2 cycles of chemotherapy to 4 cycles to 8 cycles of chemotherapy. Whereas high-risk neuroblastoma, which is the hero of neuroblastoma, is a very, very difficult yet interesting topic because it has 5 different subdivisions when you come to treat. You have an induction chemotherapy, you have consolidation, followed by a maintenance. So with regard to the risk stratification, which I'd just like to touch upon because that is very important when it comes to neuroblastoma. So earlier days, we had a surgical risk stratification. For example, in the United States, to start with, they all had surgeons as the lead pioneers in terms of treating pediatric cancers. So any tumor you get, they would operate and then follow up with subsequent treatment. So all the surgical team were involved in treating pediatric cancers, and that is where all the other branches, or rather the treatment modalities, stemmed out. Now, coming to the initial INSS, which is basically a surgical staging system, it is similar to what we see in adult as well, wherein you have a stage 1, which is completely excited. Stage 2 is a local disease, and then is a regional disease, and then is a metastatic disease. So the only drawback with this, the only drawback with this particular system was it was an initial surgical system, and it did not give us time for the pre-treatment extent of the disease. Because when you have a surgical expertise, then your chances of making a tumor stage 1 is very likely. Whereas if your surgical expertise is not very good, then chances of upstaging a disease is very high. So to unify the systems of staging, we had a task force called as an INRG, which is the International Neuroblastoma Risk Group Staging System, which was started in 2005. So they wanted a unified system to risk stratify these patients and was mainly based on image-defined risk factors, which is called as IDRF. Now, why IDRFs were chosen is all these IDRFs basically is a prerequisite to decide surgery. At the same time, it can be uniformly applied across the globe because all your CTs, when loaded in the archives, you can easily compare from different countries. Whereas if you want to do an INSS staging, one patient will be stage 1 if the child was born in one particular country and would be stage 3 if the child was born in another particular country. So this is where the role of INRG came into place, and we classify patients into 4 different stages, that is L1, L2, M, and MS. So L1 is similar to your local tumor, wherein it does not compromise on the vital structures. But L2 is a loco-regional tumor, wherein an IDRF basically means involvement of nearby structures. For example, if it is encasing a vessel, then it becomes an IDRF. If you have a paraspinal mass, which is obliterating the spinal canal, producing cord compression, then it becomes an IDRF. And M disease is when you have distant metastasis, and MS is a very special category wherein you have infants less than 18 months who have mets to the liver, to the skin and the marrow, yet have a good biology. Hence, they can be observed without requiring much of chemotherapy unless they present with life-threatening symptoms. So based on this, you have an INRG risk stratification. I'm not going too much into the details, but to simplify things, all you have to know is when you have anybody with metastasis in a child more than 18 months of age, it is classified as high risk, irrespective of the endemic status. If you have an endemic amplified neuroblastoma, it is considered as a high risk, no matter what the age, what the stage, what the other aberrations are there. So two things you have to remember. If you have a child with endemic amplification, it is considered as high risk. However, there are certain groups which exempt endemic from being used, like the Cyopin. Let us not discuss into that. Just for information. The next thing is if you have a child who is more than 18 months of age and having a marrow mets or a bony mets, then we take it as a high risk neuroblastoma. So coming to the treatment of intermediate and high risk neuroblastoma. So intermediate neuroblastoma, as I already mentioned, we use 2 to 8 cycles depending on which protocol you use. So I purposely like to highlight this recent protocol because the results of this have been really promising and it has been quite different from what we were practicing. So earlier we were actually giving VADRC, we were giving carboplatin etoposide as a treatment backbone in intermediate risk neuroblastoma. Now the COG basically used intermediate risk to subclassify them into 3 or 4 groups, and then they actually stratified them and gave different cycles of chemotherapy. I'm not going into the grouping, but if you carefully look on the left, you can find that if you fall under this particular group 2, and if you are able to achieve a PR, which is more than 50% response with just 2 cycles of chemotherapy, you can still observe these children. So all intermediate risk children do not actually require the designated 4 to 8 cycles. A subgroup of intermediate risk can get away with just 2 cycles of chemotherapy with a partial response. Now, and the other group, wherein you give 3 to 4 cycles of chemotherapy, can also be observed if you attain partial response. Similar to that, a little higher risk patients will require the entire 8 cycles of chemotherapy, and you expect a little bit of better response, which is a VGPR. VGPR is mainly a very good partial response where you need more than 90% of response from the primary assessment. So the learning point from this particular slide is that a subgroup you can get away with 2 cycles, another group you can give 4 cycles, another group you need 8 cycles with adequate response. And if any of these subgroups, if they do not achieve the necessary PR or even partial response, then there is a window of adding cyclophosphamide with topotecan. So based on the COG report, we can currently say that 2 to 8 cycles is adequate and achieving partial response is enough when you're treating these patients. And if they do not show partial response, you can add cyclophosphamide topotecan. Now, just one more point. The European counterparts treat differently. They give carboplatin and etoposide as their background to start with. And based on the response after 2 cycles, they either continue that or add anthracycline. So this way, they try to avoid anthracycline in such smaller children to prevent long-term toxicities. Now, with regard to the chemotherapy backbone in this is a little complex. So they start off with same carboplatin etoposide, similar doses as Cyopin. However, subsequently, they do add anthracycline in cycle 2 and cycle 4. So the major difference in treating intermediate risk is that the European group uses carboplatin etoposide, and once there's no response, they add doxorubicin. However, the COG group, they use doxorubicin in cycle 2 and cycle 4, which means for 2 cycles, they use anthracycline. The other way to remember is generally the American protocol is a little more aggressive when it comes to management, so they have a higher threshold to use anthracycline. Now, with regard to the high-risk neuroblastoma, we have 3 segments in managing. One is your induction chemotherapy, followed by which you plan for surgery, and then you consolidate it with an autologous stem cell rescue and an RT, and then you give a maintenance chemotherapy when immunotherapy. So induction, I'm not going to the principle, is to produce maximum reduction. Since the focus is mainly on drugs, let us look into the drugs being used. So the major difference in terms of the American and the European counterpart is that the Europeans used a platinum-based regime while the North Americans used an anthracycline or a doxorubicin-based regime. Remember, all of these drugs are very much active and there is no such superiority one over the other. Now, coming to the comparison, if you see the Europeans, the current protocol that the Cyopin recommends is called as a rapid Kojak. So I'll come back to this and then go back to the other. So there were two different protocols used by the SIOPIN. SIOPIN stands for the European Network. So the OJEC and the Kojak. So if you clearly see this, the drugs which are active in neuroblastoma latens, cyclophosphamide, etoposide, of course, vincristine. So the Europeans used two different protocols. One is the OJEC and the Kojak. So the OJEC is basically a 3-weekly regime wherein you give these drugs at a 3-weekly interval. Well, rapid Kojak, which is currently the standard of care in most centers, generally give it every 10 days. So this is similar to the dose intensity, wherein every 10 days you kind of cycle these children with chemotherapy. So if you technically see, the intensity of the chemotherapy is quite high in the Kojak group, right? So the doses are the same. Remember, the table on the left, the doses of all these drugs are the same. However, a 3-weekly regime versus a 10-day regime, if you find the dose intensity was 1.8-fold higher per week, because this is given 10 days and that is given every 21 days. So what is the advantage of giving this every 10-day chemotherapy is that you're able to ultimately finish your induction chemotherapy very fast. So subsequently, you're able to transplant them a little early. Another thing which you look at this regime is that there's no anthracycline. So we all know anthracycline always comes with a cost, and even if you don't hit the cumulative toxicity of 250 milligrams per meter square, mucositis, neutropenia is definitely known to occur with doxorubicin. So such toxicity was not noted with rapid Kojak. Now you compare with this chemotherapy regime, which is a rapid Kojak, you can clearly see that these are cycles of 10-day chemotherapy, which are given every 10 days. So it is ABCB, ABCB. Your A stands for vincristine carboplatin. B is for cisplatin vincristine, where this warrants admission because it's a 24-hour cisplatin infusion. And C is for C, which is cyclophosphamide, etoposide along with vincristine. Now, how different did the American counterparts do? So the Americans use something called as N5 regime, which is basically from the MSKCC, Memorial Sloan Kettering Center's regime. So here you see they had an anthracycline, which is a doxorubicin-based regime, which was alternated with a cisplatin etoposide. Now this is the regime which was used in a lot of centers earlier, even in treating intermediate risk neuroblastoma. Now, after you give this induction chemotherapy, you're basically going to assess for response. So when you compare with these two regimes, there was not much of a difference in terms of your outcomes. For example, if you say the toxicity profile, doxorubicin, okay, slightly higher rates of FNPs, but not statistically significant. In terms of your response rate, if you see, both of them had adequate response because most of them achieved actually 80% of them, 70 to 80% had CR or PR to induction chemotherapy with both the regimes, which means 20% still do not respond to either of these two regimes. With regard to surgical exploration, there was not much of a difference because both of them had similar rates of surgical resection. Now, what is this particular regime? So this TBD is another regime which is basically used as a salvage regime. So for example, if you have tried your rapid Kojak and then after your 80 days you do a marrow and you still find that your marrow disease is persistent, then you still have a window to try some more drugs as salvage, wherein you give 2 cycles of TBD, which is topotecan, vincristine, doxorubicin. It is given over a period of 5 days, where it is given as continuous infusions, and because of which you can actually give them a second chance to see if they achieve remission, so as to proceed with subsequent consolidation therapy. So after consolidation, we basically do the next phase of treatment, which is your radiation. Which is your autologous stem cell rescue, wherein you give conditional regime with carboplatin and etoposide, following which you take the patient for autologous stem cell rescue, and then you do your radiation and then go to the next phase, which is your post-consolidation or the maintenance. So the maintenance phase, we only remember 2 drugs. One is your immunotherapy with dintoximab, and the other is your retinoic acid. Now, retinoic acid came into existence because we all know it is a differentiating agent. It is used in adult APML. Similarly, in pediatric tumors, as you all know, all of them are blastomas, all all the blastomas, hepatovelms, etc. So most of these embryonal tumors, they have these embryonic rests which are immature cells. So to allow these rests to differentiate, retinoic acid has been used, and that is the principle of using it in maintenance chemotherapy. Of course, in terms of neuroblastoma, similar to what we have as the MRD positive in adults, the maintenance phase basically covers the MRD is basically to clear the MRD for neuroblastoma. So here the dose that we recommend is 160 mg per meter square per day, which is usually given for 2 weeks on, 2 weeks off. You give for 6 cycles. And when you're giving retinoic acid, you should be bothered about your calcium, your lipid profile, and look for cheilitis. If you have cheilitis, you're supposed to give your vitamin E application. Look for hyperpigmentation and also for your growth plate fusion. The next important thing is you look for monitor for transaminitis, and if it is significantly high, your dose adjustment has to be done. So this is with regard to your retinoic acid. Now comes the latest drug in the armamentarium, wherein dinutuximab, quite commonly asked, hype, etc. So dinutuximab is a monoclonal antibody, which is both heavy and light chains of anti-GD2. So neuroblastoma cells express this GD2, which is the ganglioside on their neural crest cells. And this GD2 is expressed even on your normal nerve cells. So whether it is your sensory nerve or whether it is your motor nerves, all of these express GD2. So what happens when you use an antibody to attack on this GD2 is basically you have a lot of cell lysis. So dinutuximab exploits the principle of both your ADCC and complement dependent. That is your antibody dependent cytotoxicity and complement mediated cytotoxicity. So once it kills the neuroblastoma cells, the cells go for lysis, and there is a small amount of immune mechanism which happens with any immunotherapy. Now, how do you administer dinutuximab? So you have different types of medicines available. The dinutuximab, which is available in the US, is different. In the European countries, it is the dinutuximab beta. So the Europeans basically had two different methods of administration schedules. One is the LTI and the other is the STI. So LTI stands for long-term infusion. So which means you give 10 milligrams per meter square per day as a continuous infusion over 10 days. So total dose amounts to 100 milligram per meter square. So you see over here, it is given for 10 continuous days. Now, the next one is the short-term infusion. So the dose is being maintained at 100 milligrams per meter square. However, it is finished at a very shorter interval. That is, you give it only for 8 hours per day and you give 20 milligrams per meter square per day. So 20 into 500, here this is 10 into 10. Now, so what actually is the difference between the two in terms of safety profile? So what was noted is whenever you had these immunotherapy related toxicity, for example, pain, hypersensitive reactions, hypotension, as I already mentioned, because of this immune reaction, whatever immune features that you see with other immunotherapy, it is seen here. You have hypersensitivity, you have capillary leak, you have hypotension, you have fever, etc. The other important additional side effect with dinutuximab is the pain. This GD2, which is expressed even in your normal nerves, can also be blocked, as a result of which it produces severe burning or a shooting pain when you give dinutuximab administration. So the European counterpart basically recommends a long-term infusion as the standard of care in dinutuximab administration, because the long-term infusion, that is a 10-day administration, has a lower incidence of dinutuximab-related pain, hypersensitivity, and hypotension. So if you clearly look at this chart, you can find that the long-term infusion and the short-term infusion, if you see, all of the side effects have been significantly less when compared to the short-term infusion. Now, what is the role of interleukin-2 here? So interleukin-2 is nothing but another immune mediator, which is going to accelerate the immune response, and that is how it came into the management of neuroblastoma. So when you're accelerating this immune mechanism by means of other cytokines, what really happens is sometimes there is an exaggerated inflammatory response. So with this exaggerated inflammation, sometimes they are more prone to get capillary leak, hypotension, and febrile reactions. So that is why in the current protocols, if you see, the SIOPIN says do not use interleukin-2, or rather it is not used. So interleukin-2 was used at 2 different doses. One is 3 international units per kg, the other is 6, but either of which it is suggested that interleukin 2 need not be used. Now, is there any prerequisite for rituximab? Yes, it is very, very important because ideally your preparatory phase starts 3 days before. So currently they get admitted 3 days before, and then you start them off with some pre-medication, which is gabapentin, which is again dose escalate. For example, if you see -3, -2, -1, you dose them at 10, 20, and 30 milligrams per kilogram. Maximum dose is 300 milligrams of gabapentin, which is the adult dose. And then to counter the pain, you start off with morphine. There are different regimes of morphine pain control. The basic thing is you start with 0.03 milligram per kg per hour and then gradually escalate or de-escalate based on tolerance. Of course, paracetamol is given when you have fever, and this fever has to be differentiated from two things, whether the fever is due to the febrile reaction or is it due to pain or due to infection. Now, when you have an accelerated immune response, your immune cells are also going to be depleted, so you can get febrile neutropenia and infections. So when you have fever with raised CRP, please rule out infection, please rule out infusion-related pain. Start with paracetamol, and depending on the clinical condition, antibiotics may be needed. Routine use is generally not recommended. Finish your rituximab injection, and subsequently, if your cycle 1 is completed, well tolerated, proceed to your cycle 2. If you have life-threatening complications with rituximab, then it is an indication to subsequently stop. For example, if you have severe hyponatremia, severe seizures, and grade 4 hypotension, which is grade 4 cytokine release syndrome, and all these things, it is better. And also for keratopathy, it has ocular toxicity as well. So for these indications, it is recommended to stop rituximab for further cycles, generally given every 35 days for 5 cycles. Now, if pain doesn't control with all these morphine and gabapentin and of course paracetamol, then you might have to escalate into other drugs. The other drugs which are used are ketamine and indomethacin, or other NSAIDs can also be used. So neuroblastoma, if you see from conventional chemotherapy, we have better outcomes with intensification using this rapid conjugate autologous HSCT. And now with immunotherapy, we've come as much as 60 to 70%. So is that all? No. Current COG protocol is trying more molecules or more targeted therapy to see if we could increase this survival rate. So the current 1531 COG study, in fact, exploits the principle of ALK positivity in neuroblastoma and to target. So if you have an ALK positive, then lorlatinib is being tried. And if you have an iron uptake in MIBG, then an MIBG is also being tried. However, we need more results to actually put it into practice. Now coming to the next embryonal tumor, which is nephroblastoma or Wilms tumor. I'll just touch upon a strategy so that you understand how you basically treat. So you have two groups. One is the Children's Oncology group from the America, and the SIOP, which is the International Society of Pediatric Oncology. So I've used the stratification from the COG. So the initial studies related to Wilms tumor were under the leadership of NWTS, which is called as National Wilms Tumor Study Group, which had a set of 5 study groups studying Wilms tumor. So earlier, it was more surgical staging. So stage was based on, the treatment was based on staging. Subsequently, we incorporated histology, age, weight of the tumor. And now in the era of genetics, we have different genetic features to guide therapy. For example, in Wilms, it is the LOH1P16Q, which has been used in the stratification. And in the subsequent studies, we are looking forward for more like 1P22Q gain, etc. So how different did the Americans manage from the Europeans? So in the United States, it is always surgery first. So you have a child with Wilms tumor, operate. That is the general dictum. Of course, there are certain conditions where you do not operate. For example, if you have a tumor which is very large and you're going to suspect it to rupture when you operate, or it is compressing the nearby structures like spleen, the pancreas, the colon, wherein you can't really get a good surgical outcome. Or if you have a large intravascular thrombus extending from the IVC into the heart, etc., then these conditions, they generally give a chemotherapy followed by surgery. Otherwise, most of the times they manage with the surgery upfront. So once you have a surgery, then you have to look into the histology. So based on the staging, you either start with something called as a 2-drug regime or a 3-drug regime. The 2-drug regime is otherwise called as the EE4A regime, which consists of vincristine and actinomycin. Now, if you have a stage 3 upfront, for example, you have a large Wilms tumor, you have a lot of regional lymph nodes, and you have an IVC thrombus, then you start with a 3-drug regime because automatically it becomes a stage 3 Wilms tumor. So you start with a 3-drug regime wherein you add doxorubicin. So you start with vincristine, actinomycin plus doxorubicin. Now, there are additional drugs which I will discuss later. Now, coming to the SIOP stands for the International Society of Pediatric Oncology, wherein they start with the neoadjuvant chemotherapy followed by surgery. So the Europeans are a little more conservative, wherein they usually start with only a 2-drug regime unless it is a metastatic disease. So they start with vincristine actinomycin, wait for 4 weeks, and then they plan for surgery. And depending on the histology, then they stratify and give the subsequent cycles of chemotherapy. Now, if it is a metastatic disease, however, they start with the 3 drugs and then they proceed for surgery. Now, based on the histology, the subsequent stratification arises. So if you have a person who undergoes surgery after 4 weeks as per SIOP, and then the report says it is completely necrotic, which means it has responded well to your 4 cycles of vincristine actinomycin, then it comes under low risk, which means you can straight away wait and watch and you don't need further cycles if it is stage 1 to start with. Now, there are certain times for which you need to give a little bit of additional chemotherapy, which comes under the intermediate risk. So that is your regressive type, epithelial, stromal type, mixed type, and a focal anaplasia type. So I'm sure we all have learned about nephroblastoma in our pathology days. It is a triphasic tumor, which means it has 3 different types of cell lines. So you have some component of epithelial, which is your tubules, and you have some component of stroma, which consists of your connective tissue, fat, muscle, and then sometimes you will have a mixed component. Now, the villains in nephroblastoma are basically the anaplasia type. So if you see focal anaplasia and diffuse anaplasia, the SIOP says both are different because focal anaplasia can be managed like intermediates. However, in the children's oncology group, the Americans generally manage anaplasia together as a high-risk group. The only other difference is this blastomal predominant component is also classified as high risk under the SIOP, but not in the COG. So now different regimes are used both in the COG and in the SIOP. So as I told you, simple way to remember, EE4 is 2 drugs, which is vincristine and actinomycin. DD4 is 3 drugs, which is vincristine, actinomycin with the doxorubicin. So when you use 2 drugs, 18 weeks of chemotherapy is adequate, and when you use 3 drugs, 24 weeks is adequate. Now, there are 2 other regimes which are also used in the COG group. So one is called as regimen I. So regimen I is used in the treatment of clear cell sarcomas of the kidney. The only difference is that it actually adds 2 drugs in addition to the vincristine doxorubicin, which is nothing but your cyclophosphamide and etoposide, and the treatment duration is similar. Now, there is another regime called as regimen M. So regimen M includes all of the 3 drugs with cyclophosphamide etoposide. So basically, it's a combination of all these drugs. So regimen M is used when you have a metastatic disease. For example, you have a Wilms tumor with lung mets, and after 6 weeks of chemotherapy, we usually start with 3 drugs for the metastatic disease. And after 6 weeks, you find that the response is not adequate. Then you might have to augment chemotherapy. 2, if you have got your report as LOH1P or 16Q+, then also you have to use your regimen M in terms of stage 3 and stage 2, because that has produced significant survival benefit. Now, this is a very complicated slide. I do not want you to remember, and neither do any of us remember. So in SIOP, basically, we have 2 things. You start with 2 drug, and then subsequently, based on the histology defined before, we give the subsequent therapy. So 2 things which you have to remember here is that the dose of doxorubicin which is used is different. So you have an AVD regime, which is 150 and AVD 250, wherein the dose of doxorubicin varies. So if you have a low risk disease in terms of stage 4, then you prefer an AVD 150. But if you have really a high risk stage 4 with the lung not responding properly, then you'd have to go for a 250 milligrams of doxorubicin for that region. Now, a brief overview of what is done in bilateral Wilms tumor. The basic principles of bilateral Wilms tumor is that The tumor is seen in both the kidneys, so you can't take away both the kidneys. So you're going to implement something called as a nephron sparing surgery. So you're trying to preserve as much as renal tissue so that you preserve end-stage renal disease. So in these patients, both the groups, whether it is the American or the European, they all start with a neoadjuvant chemotherapy. So the Americans usually start with 3-drug chemotherapy, while PSYOP actually uses only a 2-drug chemotherapy. So you do a response after week 6. And after you do a response assessment, if you find that you've got adequate partial response, which is more than enough, then you can see if nephrectomy is partial nephrectomy or nephron sparing surgery is feasible. If it is feasible, then you proceed for surgery and then you plan your adjuvant chemotherapy. Now, if you do not have a partial response at week 6, then you give subsequent cycles and wait till week 12. Now, if you find that nothing is feasible and there is no response, then your plan of management will vary. Now, a few things with regard to the initial neoadjuvant chemotherapy. Now, if you see, 2-drug regime is what is following, whereas the COG, that is the American group, based on this study, they found that to facilitate nephron sparing surgery, the initial neoadjuvant chemotherapy is something called as a V8, that is your vincristine, actinomycin, doxorubicin. It is not your DD4A. The main difference is that in your DD4, that is in your DD4, the dose of doxorubicin used in the neoadjuvant setting is only 60 milligrams per meter square, whereas in your VAD, it comes to 105. So 3 doses of doxorubicin are used before surgery in bilateral Wilms tumor, whereas in the DD4 regime, only 2 doses of doxorubicin is used. So the added advantage is you can facilitate nephron sparing surgery a little more easily with this VAD. So this is used in bilateral Wilms tumor. So the dose used there in terms of DD4A is 30 plus 30, 60 milligrams before surgery. Here we use 105, 35, 35, 35. Okay. So if you clearly see this VAD, which is used only in the neoadjuvant setting, that is before you attain surgery, that is nephron sparing surgery for bilateral Wilms tumor, and the duration is only for 2 weeks. So this regime doesn't exist after that. It is only your NACT regimen, it is not your adjuvant regime. And after you get your bilateral Wilms tumor histology, then you plan your treatment accordingly. Suppose you have clear cell sarcoma is never bilateral, but subsequently, suppose you have in one side any doubtful things, then you're supposed to treat according to the regime. The other regimes is your regime I and UH1. Now, the UH1 is similar to the intense protocol that we use for sarcoma, which is your VADRC alternating with carboplatin, and it represents quite an intense regime with high rates of febrile neutropenia, and the duration is also longer, wherein you give for 31 weeks. I'll not cover about RT because that is not the scope of this lecture. The next is our embryonal liver tumor, which is the hepatoblastoma. Hepatoblastoma, we have 2 risk stratification. One is your standard risk, the other is your high risk. So in standard risk hepatoblastoma, there were 2 regimes which are being compared. One is the single agent cisplatin. Now, one thing you must remember, the platinums are the most active agents used in hepatoblastoma. So considering this, cisplatin was being used. So the first thing was the PSYOP studies initially started off with the PLADO. So the PLADO basically stands for Pla plus Do. Pla stands for platinum, Do for doxo. So cisplatin was given at 80 milligrams per meter square for 24 hours, and doxorubicin was also given at 60 mg per meter square as a continuous infusion. Now, what was subsequently found that whether you give cisplatin or you give cisplatin plus doxorubicin together, it was found that there was not much of a difference in terms of survival. Whether the toxicity was it any different? No. So from this PSYOP 3 study, it was clearly found that cisplatin was definitely non-inferior in treating standard risk hepatoblastoma patients when compared to that of your PLADO regime. So this paved the way that you have a standard risk hepatoblastoma, you can actually avoid doxorubicin. I know some centers still give PLADO for treating standard risk hepatoblastoma, which is still not wrong because ultimately there's not much of a difference in terms of toxicity profile as well. But however, if you could avoid doxorubicin, it is well and good. So the current practice is to use a single agent cisplatin, which is given every 2 weekly. If you see here, it is 80 milligram per meter square given every 2 weekly. And then after 4 cycles, you plan for a surgery and you can complete with 2 more cycles, counting to a total of 6 cycles. Now, quite sometimes what we practically see, maybe not to mention protocols, is after you treat here, sometimes you might have some amount of, elevated AFP or not so expected response. And a lot of times we do shift to Plado, that is giving a small dose of doxorubicin and followed these children. But if you ask whether there's any evidence, I think it is just for practical reasons. Now, how do you manage high-risk hepatoblastoma? So standard hepatoblastoma, single agent cisplatin every 2 weeks, total of 6 cycles, surgery after 4 weeks. Now, how different is high-risk hepatoblastoma? So high-risk hepatoblastoma is a little more aggressive, so the treatment is also based on the similar principle. So as I mentioned, cisplatinums are the most active agents in hepatoblastomas. So using this principle, they thought of adding another drug, which is carboplatin. And this regime is otherwise called as a super Plado. So you're adding a super drug, which is carboplatin, to the existing Plado. So how did they alternate? Cisplatin, carbodoxy, cisplatin, carbodoxy, cisplatin, carbodoxy. So a total of 5 cycles. Actually, each of this is 1 cycle. So if you see here, this is 1 cycle, this is another, and this is another. So your initial point of assessment actually comes after 2 cycles, which is 4 courses of chemotherapy. So each cycle has 2 courses of chemotherapy. Now coming to the dosage. So cisplatin is given at 80 mg, carboplatin is given as 500 mg per meter square, and doxo is given as 60 mg per meter square. So the only problem is all these admissions all these chemotherapy cycles require admission because they all have a 24-hour infusion for CDDP and a 48-hour infusion for doxorubicin. Now, something very different in pediatric oncology is the milligram per kilogram, or the dosage in terms of chemotherapy. So all of you use your milligrams per meter square per dose. In terms of pediatrics, it is slightly different. Most of these hepatoblastoma children are generally around 10 kgs or even less. So you need to follow the milligram per kilogram. General dictum that we all know is every 30 kilograms is equivalent to 1 meter square. So if you have a child, if you want to calculate it, you have to divide by 30. So 80 divided by 30 comes to 2.6. So if you have a child less than 5 kilograms, then there is a further 1/3 reduction. So for example, if you have doxorubicin dose for a child less than 10 kilograms, 1 milligram per kilogram, then you reduce it by 1/3, which is 0.6 for a child less than 5 kilograms. Sometimes we do get patients with congenital hepatoblastoma or in the early infancy. So for all these children, this dosing is very important. Now, coming to cisplatin, less than 10 kilograms, it is 2.6 milligram per kilogram, and less than 5 kilograms, it is 1.7. So the protocol itself says that you start with 1.7 milligram for a child less than 5, and if they tolerate subsequently, you can also increase to 2.6. That is point 1. Point 2, most of these babies ultimately gain weight. So in your cycle 1, if they are 3.5 to 4 kilos, by the time they reach cycle 4, they might also be 5 or 6 kilos if nutrition is taken care of. So each chemotherapy cycle weight check is a very, very important parameter. If the staffs are not doing it, we have to make sure it is being done. Coming to carboplatin, for a less than 10 kilo child, it is 16.6, and for more than 10, it is, for a less than 5, it is 11.5. So this basically super Plado regime used in high-risk hepatoblastoma had good results with survival of 65% and achieving good CR rates for lung metastasis and surgical resection being as high as 76%. Now, so what paved the way for another side? So based on the principle that cisplatin is very good for hepatoblastoma, the dose density came once again into picture. So for all the other high risk, as per Cycle 4, what they thought is we can give a little more intense cisplatin. So if cisplatin is active, why not finish off all the cisplatin even before surgery so that we can get maximum results? And that is what was proved in this study. So here, if you see, there were 3 cycles of NACT. So 1 cycle, that is block 1, 2, 3, and then you plan for surgery. If surgery is feasible, you give something called as block C, which is less intense. If surgery is not feasible, then you give block B, which is a little more higher dose of chemotherapy, and then finally do the surgery and finish it off. So what happened in the NACT arm, if you see, so this is not an RCT, this was just not an RCT, it was done for all high risk patients because the numbers were very less. So The first cycle, they start with 80 milligrams on day 1. The reason being, suppose you have a child with high risk rupture, it will take some time for you to actually get a radiological report to stratify this patient into this particular arm. So the 80 mg per meter square is common, even if you're starting super plateau, right? And then based on this, if the child fits into this particular criteria of high risk, that is rupture, etc., as per cycle 4, then they would, and consent is given, then they would proceed to the cycle 4 high risk, which is your dose dense cisplatin. So that's why they started with 80 and subsequently made it 70, 70, 70. So imagine a child who's going through 80 plus so many cycles of 70 milligram per meter square cisplatin. It amounts up to 570 milligrams per meter square of cisplatin within this short interval, correct? So 80 plus 70, 70, 70, 70, 70. So 570 milligrams per meter square, which is the toxic limit of cisplatin, is being used even before NACT. And doxorubicin is given at 60 per cycle, so which amounts to 180. So 180 doxo and 570 cisplatin is used before NACT, and that is how this study had very good results of surgical resection. Now, after surgery, if at all you achieved good resection, then you just consolidate with chemotherapy, which is nothing but your carboplatin doxo. You've exhausted your cisplatin, so next go for carboplatin and use doxorubicin, which is a little low dose, 20 per meter square. So that is 40, 40, 40, 120. So 180 there and 120 here, you're reaching 300 of doxorubicin, and carboplatin here comes to 500 fan, which is 1.5 grams, and 570 of cisplatin. Now, if the child did not achieve good surgical resection, then what do? You've already given 570 cisplatin. You go ahead with high doses of carboplatin. So carboplatin AUC of 10.6 is quite a high dose, which is 800 per meter square. So 800 and 800, you're giving 1.6 gram per meter square. Now look at doxo. 75 in one cycle given over 3 days. 75 in the other cycle, so 150. So the only problem with this is you're actually exceeding the cumulative nth second, because you've already given 180 there, and now you're giving another 150 here, which comes to 330. So this is quite a very intense regime, though the success rates of this study was very good. However, it did have its own toxicity. This is just the dosage which is given in kilogram, nothing different. Now, one thing with regard to the carboplatin dosage, which is very peculiar to pediatrics, we all know that in adults, if I'm aware, you cap it at a dose of 125 GFR, and then based on the AUC, you multiply it. Some people add 125 plus 25 into the AUC as well. So if you want an AUC of 8, you take 125 plus 25, 150 into 8, which is 1200, etc. In pediatrics, however, we are a little more careful. So we generally have this milligram per meter square converted to milligram per kilogram for all practical reasons, and that is what has been routinely followed. Though protocols actually have a little more rigorous way of dealing the whole system. So what they have recommended is you ideally have a DTP functional assay of the renal system, so that you have your GFR calculated, then you look for the body weight, and then you plot. So for example, if you have a 10 kilo child who's having a GFR of 150, then your dose will be 205 as per this chart. So based on this, you give your total dose of carboplatin. Technically speaking, the doses are not very different. Definitely, this dose is slightly lesser than what you calculate milligrams per kg, and the daily dose is what is recommended. Now, the other alternate way is you can't have a DTPA practically for all children. It is not available at all centers, and every time you can't keep doing. So the other easy way is to calculate your GFR by means of using Schwartz formula. The Schwartz formula is a formula which we use in pediatrics. It is similar to your Cocker-Groft formula. I know Cocker-Groft is kind of obsolete in adults, but the Schwartz formula is still relevant in pediatrics. So based on that, we calculate the half-life. We'll calculate the GFR, and then we can still plot. So different ways of doing carboplatin dosage, especially in some children when they have large lesions, and then some pediatric patients do have hydronephrosis even other ways. So in such conditions, we're more worried about the renal functions, etc. So in those conditions, it is always better to, dose it adequately, if feasible, to have a proper functional assay. Now, come to the toxicity. We all know cisplatin ototoxicity, and there are different grading systems. I'm not going into that. The Brox was on the earliest staging systems, and subsequently we've got the SIOP. more or less similar, but the only thing is the Munster and the SIAP and all have early rates of picking up, and anybody who's more than grade 3 or grade 4 is considered to have significant hearing loss. And most protocols, in fact, use the Brock's grading system for finding out cisplatin-induced hearing loss. Generally, the higher frequencies are affected first, if you see, and then only the lower frequency. So anybody more than 40 decibels when at 2 kilohertz or 2000 hertz, then it is significant hearing loss. If you go as per SIOP, it is 20 decibels at 2 kilohertz. Here it is 40 decibels at 2 kilohertz. So this I have discussed. SIAPL 4, that intense dose regime is very, very rewarding in terms of results. Not to forget, toxicity rates were very high. You see ototoxicity in 30%, hematological toxicity in one sect was 97%, and FNPs were 70%. My personal experience, we had a hepatoblastoma with ruptured liver and hemoperitoneum with hemodynamic instability. We gave a SIAPL 4 chemotherapy, and thankfully the child is alive with no ototoxicity as of now. Now coming to the other two tumors, next is retinoblastoma. Quick thing about RB, you have a grouping, you have a staging. Grouping is generally done under anesthesia, and then you look for the intraocular extent. Now ABC, it is basically small tumors are come under the A and B, and when you have seedings, it is group C, and if you have less than 3 millimeters, C. If it is more than 3, it is D. And group E is something which we're really worried about, because then E for E, when you have group E, you have to enucleate instead of just giving chemotherapy per se. So when you have a large lesion, which is occupying more than 50%, when you have aseptic cellulitis, you have neovascularization leading on to glaucoma, you have phthisis bulbi, and when you have the retrolaminar spread or the postlaminar spread, and then if it is involving the sclera and orbit of the anterior chamber, then it comes to group E. All these are high risk features in terms of EUA. I'll not go through this. Next is the staging. So staging basically is you have an intraocular retinoblastoma, you have an extraocular retinoblastoma. So once the disease is outside the globe, then the chances of METs is very high, and that definitely warrants systemic chemotherapy with radiation as well. So this is similar to your staging in others, wherein you have a complete surgery, it is 1. If you have surgery with positive margins, it is stage 2. If you have regional involvement with nodes and orbital disease, it is stage 3. Stage 4 is METs. If you have in the blood, then it is A. If you have in the CNS, it is 4B. So with regard to management of retinoblastoma, now retinoblastoma is a very, very controversial thing, because you have two options. One is globe salvage, and the other is life. So most of the ocular oncologists, for them, if you see, they would think that globe salvage is of priority, but however, as pediatric oncologists, I think for us, life comes more important than the eye. So the treatment is basically a combination of so many different things. You have focal therapies, you have intraocular chemotherapy, you have, and your systemic with intravenous chemotherapy. I'm not going into intraocular chemotherapy because that is a little different topic per se. Now coming to intravenous chemotherapy, one thing we should understand, if you have a group E, as mentioned, it is an indication for upfront enucleation. However, practically it is not possible, because most of the patients do not go for an upfront enucleation, and same thing, the ocular oncologist also would generally not do it upfront. So we are left with the option of giving a NACT, that is a neoadjuvant chemotherapy for all these patients. If you have an upfront group A, and for group B, still people do try local therapies, and then they come depending on the response for your subsequent chemotherapy. Based on the response, you can subsequently give them few cycles of chemotherapy. Now, the most controversial part is your group D. So when you have a group D, which is like large seeds, then your problem is the chemotherapy may not actually work. So then you might have to give intra-arterial chemotherapy, which makes sense. But whether your arterial chemotherapy is going to be of great benefit, we still do not know. I know there are papers which suggest its benefit, but there is a lot of controversy when it comes to group D. Now coming to bilateral retinoblastoma, one thing which you should remember, chemotherapy is definitely of a role you cannot avoid, because chemotherapy is going to prevent your subsequent pinealoblastomas if they have to occur in the later stages of life, because bilateral retinoblastoma has something to do with genetic predisposition. So it is very important that you screen them at the same time you manage. So when you have a group when you have bilateral retinoblastoma, basically you have to group both the eyes, right and the left eye, and the management principle is basically based on the most severely affected eye. For example, you have B and E, then your management will be like your group E. If you have two focal lesions, like if it is like A or group B, if it is bilateral group A, you can still get away with focal therapy. But if you have group B on one to start with, and plus it is a group B or C on the other, then definitely chemotherapy is recommended. Subsequently, you go for response assessment and then decide. Now,
Sir,
few words.
sir, in the interest of time, I just wanted to let you know we have 5 more minutes.
Sure. I'll wrap it. Sure. Yeah. Next is your extraocular retinoblastoma. So extraocular retinoblastoma also has the same principle wherein you use chemotherapy with radiation. So the number of cycles that we generally recommend is 12 cycles. So if you have gross residue, if you have a stage 2, then you can actually give 12 cycles. Stage 3 also you give 12 cycles. However, you try an NACT, try to reduce it, then plan for surgery. And if you have a stage 4, now this is very important because if you have a stage 4 retinoblastoma, if you have a marrow mets, there is still a role for autologous stem cell rescue. If you have CNS, it is better to leave that child because palliation will be your intent. So extraocular retinoblastoma, stage 4, marrow mets, please try autologous stem cell rescue because it is provided survival benefit. If it is CNS mets, it is palliation. Now, one line about standard dose and the high dose. Standard dose vincristine is what is mentioned here. So carboplatin, which is 18.6, and etoposide is 5 mg per kilogram. Now, the high dose CEV, which is your high dose of carboplatin 25 mg, there is an Adyar paper which showed that the high dose was well tolerated. However, there was not much of a difference in terms of outcomes. So if you want to choose between your standard dose versus high dose chemotherapy, standard dose chemotherapy is the answer of choice, and high dose is not any better. Now, alternate drugs like ifosfamide, doxorubicin, topotecan have all been used in retinoblastoma. And with regard to extraocular retinoblastoma with with metastasis, then there is a role of autologous stem cell rescue where you use an induction followed by a consolidation and stem cell rescue. The 2 lines about medulloblastoma, I'm not going to the stratification. You have 2 risks under medulla. One is your average risk and the other is your high risk. So if you have a gross residual disease with metastasis and a child who is less than 3 years, then it becomes high risk because a 3-year-old child you cannot irradiate. So these children, you have to go for a baby brain protocol, and then you have to plan for irradiation at 2.5 to 3 years. So in medulloblastoma, you have a surgery followed by radiation, and then you have your adjuvant chemo. So the chemo regimes which are used is the vincristine, cisplatin with low-mass CCNU, and the other regime is your vincristine, cisplatin, cyclophosphamide. Okay. So now what is the, I'll not go for this. So what happens is you do a surgery and then you go for radiation. In terms of radiation, during the time of radiation, there is a concept of radiosensitizer. So vincristine is being used in adults. We use cisplatin in head and neck malignancies and CNS. In terms of pediatrics, VCR is one drug which is used as a radiosensitizer. The other drug which slowly found its place is carboplatin. Carboplatin, when used in medulloblastoma high-risk patients, it was found that in one particular subset, so medulloblastoma has 4 groups. That is the WNT, SHH, group 3, group 4. In group 3 patients, it was found that when carboplatin was administered before radiation, it was found that these patients had a survival or an event-free survival advantage. So this is the principle of using carboplatin as a radiosensitizer in treating high-risk medulloblastoma, only group 3. Other groups, it did not show any effect. And the dose used is very low. It is only 35 per meter square per day. Ideally, you give it as an infusion over 1 hour before, take the child for radiation thereafter, and do like this for 6 weeks to complete your 40. So this is the graph which shows advantage of carboplatin only in one particular subset of the high-risk medulloblastoma. Newer drugs, there is bismuth-degib in SHH medulloblastoma, and in your group 3, group 4, we have formulations of gemcitabine, pemetrexed being tried. Now, just 2 lines about lymphoblastic leukemia. We all know that survival rates have significantly improved from close to 10 to 20% to 80 to 90%. So what really improved outcomes? If you see traditionally the chemotherapy agents, whatever we've been using, it's all been found before 1970s. Okay, nothing new has been added in terms of the chemotherapy regimes. Then 2000 and found a saga of immunotherapy wherein you have different molecules being used, CD20, CD22, CD19, then other forms of immunotherapy. So basically, it's a portfolio. You have different drugs acting at different parts of the cell at different levels. One is the transcription, one is the translation, the other is protein synthesis inhibition, the other is microtubule inhibitor, etc. The other is the salvage pathway. So all these drugs exploit different pathways based on the leukemic cell, and that is the reason why we use a combination of drugs in acute leukemia. So two things. The earlier days we used, the treatment principle is more or less the same as what we use in adults, the induction, consolidation, delayed intensification, consolidation, which is also called by different names. However, the choice of drugs in terms of treating leukemia, one major significance is that we use dexamethasone and TALL. I think adults still are a little reluctant to use dexamethasone. Same thing in pediatrics, more than 10 years, it's a high risk to be associated with a lot of metabolic complications, AVN, hyperglycemia, and hypertension. The second is your asparaginase. So asparaginase, again, in adults protocols, I think it is not being used, but our pediatrics, it's one of our favorite drugs, albeit we are worried about the hypersensitivity and the pancreatitis, which are really scary for management. So this is what happens in BALL. We generally use a steroid backbone, which is prednisolone, which is 3-drug, and we add an anthracycline if it is a high risk. And if we have a T, we use an induction steroid as dexamethasone. Now coming to TALL, something new is your nelarabine, which has been currently accepted as in both the United States and in the UK. In the United States, as I said already, they're very intense. So after the consolidation, basically they start with nelarabine and then in DI. Whereas in the UK, it is basically response-based. Only if you have persistent MRD positive, you give nelarabine. Now, immunotherapy, the 3 ABCs, one is your antibody drug conjugate, B is a bispecific antibody, and C is CAR. So this exploits the principle of all the molecules which are targeting the cell surface antigens on the cancer cell. So blinatumomab, which is commonly used in relapsed refractory BAL, basically it's a bispecific, which is CD3 from T cell and the CD19 on the B cell. It binds these two and then make sure that the cell lyses or the cancer cell kills. And in the event, because of the immune reaction, you have a lot of cytokines being released, leading on to cytokine release syndrome and neurotoxicity. Similar to that is your inotuzumab ozagamicin, which acts on CD22. So what happens is inotuzumab per se, it has 3 components to it. One is CD22, one is a linker, and the other is the calcimicin, which is a toxic element. So one important side effect with that is your veno-occlusive disease, which is seen as high as 21% in the study that we which was used in pediatric patients. And especially when you go for transplant, these children find it very difficult with the high rates of VOD. Thank you. I'm sorry I had to overshoot time because.
Thank you, Dr. Nandakumar. That was a very comprehensive presentation. You have touched upon all the relevant pediatric tumors and very updated standard of care regimens for these tumors. Just a few observations from my side. Since this audience consists of both pediatric oncology as well as medical oncology trainees, some of the basic concept that we need to understand when we are treating pediatric patients with cancer is that compared to adults, pediatric patients do have they have better outcomes, and these outcomes are based on the intensity of treatment that we give. So treatment-related morbidity and mortality is unacceptable, but we have to understand that the pediatric patients are more likely to tolerate these intense regimens. As you can see, you already observed, you heard from Dr. Nandakumar, many of these regimens are very dose intense and dose dense. This will not be tolerated by elderly adult patients. Okay. But the whole goal of maintaining such intensity is that we can deliver much better outcomes. And that will come at a cost that has to be matched with good quality supportive care. Unfortunately, in our country, there is one big area where we have lagged behind. As Dr. Nandakumar rightly pointed out, most of the drugs that we commonly use are decades old. There are very few drugs which have been added to our armamentarium in the last couple of decades. All these drugs are, regimens are permutations and combinations of the same old drugs. So the efficacy is one, meticulously following the regimens as per the design protocol. Second is to provide the required supportive care. The 10 to 15% difference in outcome between the Western data and our data is primarily, I believe, due to the lack of supportive care. For the lack of supportive care, we have to often compromise the treatment. And when we do not compromise and give full intensity treatment, the patients have to bear the brunt of toxicity. So this balance has to be achieved, which I believe can be achieved only by improving that. So that is one important concept that should be a takeaway from today's session. Second is the impact of treatment on the long-term survival. There are a lot of long-term issues that the children are likely to face more than the adults. Obviously, because of good survivorship, and they are going to be long-term survivors, and they will live to see the impact of these drugs long-term. So, with these words, I will summarize the talk that Dr. Nandakumar just gave, and we will proceed on to the next part of the topic, which is Viva on the drugs commonly used in pediatric oncology. Over to you, sir. Dr. Samir Bakhshi will lead the session now.
Okay, thank you so much. So shall I share the screen? Is that how you want to do it?
Yes, sir, you can do that, sir.
Okay, so I will share the screen. Let me see if I can. How to share. Okay. Is the screen visible?
No, sir, it is not visible.
It's not visible.
Yes, sir.
So if you want, we can share it from our
I
side.
think maybe you can share it. That will be simpler for me then.
Sure,
Sure,
sir.
sir, sure.
Dishan,
Okay, so
please do
please
the
share
next
it
one.
for me. Please share it. And who is the person who is in front of me that I have to ask the questions, and from there I'll take the discussion forward? Is
Sir,
it
Dr. Rashmi Pradhan is the examinee for the day.
okay? And
Good afternoon,
Dr.
sir.
Rashmi, hello, Rashmi. May I
Yes.
just know your background? Where are you?
Sir, I am pursuing my degree in medical oncology in TMH Mumbai, sir.
Okay, great. So let's start then the discussion. I will learn from you, we'll learn from others, and we'll share some interesting questions that have been prepared by Dr. Nandakumar, and I'll take the discussion from there. So may I
Yes,
have
sir.
the next slide? Okay, so we'll start with the first case. This is a 2-year-old male child who was found on evaluation that he had abdominal pain and had a retroperitoneal mass. The CT scan of the abdomen showed a large retroperitoneal lesion with multiple intra-abdominal nodes and calcifications, and the histopathology was suggestive of neuroblastoma, and the staging showed marrow involvement. The PET scan also showed additionally uptake in the retroperitoneal lesions, multiple abdominal nodes, and uptake in some of the spinal bones as well as the skull bone. His NMIC and segmental chromosome aberrations are awaited. So let me just broadly ask you, what type of risk stratification you would like to place this child in?
Sir, NMIC is awaited, but this is more than 18 months and metastatic disease. So it's non-infantile metastatic will be high risk, sir.
Okay, perfect. So it is a high risk disease irrespective of the NMIC amplification. So may I know from you, what is your broad plan of therapy? Broad plan.
Sir, we can, as sir told, we can because it is a high risk neuroblastoma, we can go ahead with the intensive therapy, that is a rapid Kojak, in which we can give chemotherapy every 10 days for eight cycles.
Okay. So I want the broad principle. So you will give neoadjuvant
Yes, sir.
chemotherapy, and
So
then
will
what?
induction,
And
sir,
then what?
induction
So
chemotherapy.
you will give induction chemotherapy. Thereafter,
Sir, we will sir, induction and consolidation is there. So induction chemotherapy, then response assessment. If the response is good, we will go ahead with resection, sir.
okay. So let's say you give whatever chemotherapy you choose, after 4 to 6 cycles, the metastatic sites disappear, and now you have a localized tumor in the belly. The blood vessels are encased, and the surgeon says that I feel that there is a pretty big risk of doing the surgery. I can take out 90% of the tumor, but that's where it is. The patient is otherwise fine. What's your next step?
Sir, so we can go ahead with the resection, sir. And
So you want to go with the resection even if it is only 90% resection and not an R0? Is that what you are saying?
yes, sir, we can consolidate it later.
Okay. So there are two approaches to it. If you reach a situation where the surgeon thinks you cannot operate, one of the approaches is that you can perhaps go for, if the metastatic sites have gone, the marrow is negative, you can go for the autologous transplant. And in the post-transplant setting, you can either give local radiotherapy and then look at a surgery. There has been a lot of debate on doing very invasive surgeries when you can't get an R0 in a disseminated metastatic disease. So that was one point I wanted to bring forth. My next point that I want to bring forth before you is that you said rapid co-check. Let's say if I don't use rapid co-check, I use just the same combination of drugs. Am I terribly wrong or am I okay?
So not terribly wrong, sir. It is okay. Just that the intensity increases 1.8 times. We are using the same drug and the same total cumulative dose, sir, except
Okay.
vincristine.
So I will not be terribly wrong if I do not use rapid co-check. In terms of final outcomes on survival, so you may get a better response, you may be able to do your transplant earlier, but in terms of the final outcomes of overall survival, perhaps the difference is not that great that you say that this is the only mode of treatment. This is one of the modes, but not the only mode of treatment. Okay. So I want to shift gears here and ask you, this child is 2 years old. And there was a lot of questions on body surface area, weight. You want to base say, I will change this age to 10 months. Okay. And let's say there is a standard dose of, I will say there is a dose of doxorubicin. I'll just say, for example, 30 milligram per meter square. That is the dose in a particular protocol. You have an adult or a neuroblastoma protocol, which is based for children above 5 years. You have 30 milligram per meter square dose. What dose of doxorubicin you want to use at 9 months, and the weight of the child is 8 kgs or 7 kgs?
Sir, I am not very sure, but 1 mg per kg, I'm not sure, sir.
Okay. So I wanted to give a message. So there was a discussion on milligram per kg dose. So if you did not know the milligram per kg dose for that, if you look at many protocols, they will say make the dose for that is, if you calculate the dose based on surface area for an infant, the dose will be relatively higher and toxic for that age. So you can either use a weight cutoff or you can use an age cutoff. But below 1 year, you go to 50% dose. So let's just take an example. I will take an example of retinoblastoma. In retinoblastoma, the dose of carboplatin is 560 milligram per meter square. But the dose that you use in terms of weight is 18.6 milligram per kg. So assuming the weight of the child is 8 kg, and if you use 18.6 into 8, how much would that translate into? Approximately 150, 140 or 150, right?
Yes.
For an 8 kg child, the surface area is likely to be somewhere around 0.4. Okay. So multiply 560 by 0.4.
140, sir.
No.
Oh,
Again, 560 into 0.4.
yes, sir. 516.4 will be around more than 2,600.
It will be around 220 or 200.
Sorry, 220. Yes, sir. Yes.
So if you use surface area for an infant or a smaller, lower kg, below 10 kg, your total dose is likely to be 60 to 90 or 100% higher than what you will get if it is based on weight. Okay, so that is why you say either you cut the dose by 50% or you have a separate weight based doses in smaller children. That is the message I wanted to give you. We can go to the next slide. Okay, so coming to this, you would like to transplant, you will do an autologous stem cell rescue, you will give radiotherapy, and then you want to give maintenance with denutuximab and retinoic acid. That is what if you had the best case scenario. Unfortunately, denutuximab is not yet approved in the Indian market. So obviously, most of us find it very tough to use because for a single dose, it will come to, I think it will come to around 75 lakhs or something like that. So it is not routinely used. It may be used once in a while, but not routinely used. What is the, I'm very particular that you know the capsule sizes. The cis retinoic acid comes in what milligram capsules?
Sir, sorry.
You are not sure.
10 mg, sir.
So it comes as 20 milligram. Okay. Please don't write 25 milligram of retinoic acid BD once a day, twice a day. You have to know that what milligram capsule you can offer to the patient. It comes as a 20 milligram strength. Okay. So that's one thing that I wanted to share. And we can go to the next slide now. Okay. So one word about this denutuximab, even if you have not had a chance to use, have you used it in your practice here?
Sir, I'm not in pediatric oncology,
No,
so
okay. Okay.
No, sir, I
Very
have
few.
not.
So you have not used it. Okay. So denutuximab, I want you to highlight one side effect of during administration that the people should be aware of, which is different from other side effects of other targeted or immunotherapies.
Sir, anaphylaxis, sir.
Anaphylaxis is caused in many drugs.
Mhm.
Even rituximab will cause chills, rigors, all those things. Very
Sir,
specific, which actually Dr. Nandakumar brought it out.
sir, that pain, severe pain, sir,
Very good.
neuropathic pain.
Excellent. Excellent. Pain. And why does it cause pain?
Sir, because the nerve tissues also have a GD2, so it binds to it and causes.
Perfect. Perfect. So the pain can be bad enough that in the protocol, sometimes you should be prepared to use even ketamine. It is that bad. I have not experienced it. I don't know, but I'm aware that people may have to use morphine and ketamine for the pain that it might cause. We can go to the next slide. We can go to the next slide. Okay, let's come to this question now. A 20-month-old toddler presented with a paraspinal mass and a spinal cord compression. He underwent laminectomy at an outside center and HPR was neuroblastoma. Staging workup revealed no marrow involvement and PET-CT showed uptake only in the primary site and no metastasis. His NMIC was not amplified. He was diagnosed as intermediate risk neuroblastoma. So what sort of treatment you want to give to this patient?
Sir, so intermediate risk is it's a very diverse group, sir. So, but this patient has significant clinical like spinal cord compression is there. So I think 4 to 8 cycles of chemotherapy.
Okay, perfect. I'm okay with that. I'm not actually going into what drugs and what cycles you would like to give. I just want to initiate the conversation based on this because today's conversation is more on actual drugs rather than and a very broad principle. So you will give some chemotherapy 4 to 6 cycles, and you will treat this patient with that. So can you name the drugs for the benefit of the audience? What are the 4 or 5 key drugs that are effective in neuroblastoma? Just name the drugs.
Sir, cyclophosphamide, vincristine, doxorubicin,
Okay.
carboplatin, etoposide.
Very good. Very good. Absolutely excellent. You have answered all the drugs perfectly fine. So, uh, carboplatin. Okay. How do you, what is the problem with carboplatin? What are the specific side effects of carboplatin? How do you give that? I want to give 150, I want to give 200 milligrams of carboplatin. How would you give that? Tell me. How will you administer it?
Sir,
You will dissolve it in what?
sir, we usually dissolve it in 5% dextrose, sir,
Okay. Or you can also use
or
normal
in
saline.
normal saline also. Yes, sir, we
Okay,
can use
very
normal
good.
saline.
Okay. Then
And
what are the, you will administer it. What are
uh,
the side effects which are different from cisplatin? Or for carboplatin, what are the side effects which are different from cisplatin?
sir, so more thrombocytopenia.
So it causes myelosuppression and
Myelosuppression.
specifically thrombocytopenia. Very good. Excellent. What else? What does it not cause?
Sir, it is not cardiotoxic, sir, as much as
Cardiotoxic, so
cisplatin.
cisplatin is also not there. Cisplatin is not cardiotoxic, not to my
Sir,
knowledge.
sir, less autotoxic,
Okay, so it is not so autotoxic. It is not so neurotoxic.
neurotoxic.
Okay, there is no defined cardiotoxicity of cisplatin. Okay, carboplatin, can it cause hypersensitivity?
Yes,
When? In the first cycle? Second
not sure,
cycle?
sir.
Okay. So carboplatin typically has this unique property that as the number of cycles increase, it can cause hypersensitivity to somewhere in the ninth cycle, 10th cycle. You may get a call from the daycare, oh, I was infusing carboplatin and this patient has developed a hypersensitivity reaction. Okay, so carboplatin has this unique point that it develops hypersensitivity as you go further in the treatment. And this becomes a problem sometimes in retinoblastoma, where you have to use cycles beyond 6. Okay, okay, let's go further. Next slide. Let's go to the next. Okay, so herein you have a 4-year-old boy who underwent a left-sided radical nephrourectectomy with lymph node sampling for the left renal mass, and he was diagnosed with a left renal non-metastatic Wilms tumor. Histology was triphasic Wilms tumor with margins and lymph nodes being negative. He was treated with EE4A regimen, which is VCR and actinomycin D. Post week 12, he came with progressive abdominal distension and tachypnea with decreased urine output. On examination, he has ascites, liver enlargement, and weight gain of 2.1 kg. So before I go to 12 weeks, I want to ask you what is the vincristine wild strength? In what milligrams the wild strength comes?
So it comes in 1 mg, sir.
Okay, actinomycin D.
It actinomycin 2 mg, sir.
No.
1 mg, sir. It's 1.5.
0.5.
Sorry, sir.
Okay. What is the color of actinomycin D? Or you just order actinomycin D, huh? You use it in adult tumors? Tell me
Yes, sir.
which adult tumor you use actinomycin D.
So we use in, sir, GTN, sir. We use
Very
in
good,
GTN.
very good. What else? Also seen in children, but also in adults sometimes.
Sir, soft tissue sarcomas we use, sir.
Rhabdomyosarcoma. Good, very good. So it is
Color.
color. You haven't told me. I like color of the drugs. It is amber
So
colored. It is amber colored. Okay, amber colored. What is the precaution that you will take when you are administering VCR and actinomycin D? Do you give it as an infusion in 5% dextrose, saline, or what else? Or how do you give it? Over 1 hour, over 5 hours, over how do you give it? Intramuscular, oral,
So
IV?
these are both are slow IV bolus injections,
Very
sir.
good. IV bolus. Never give intramuscular. They are, what is the major side effect?
Extravasation, sir.
So they are very strong vesicants, very
Vesicants.
strong. If they come out of the vein, then you are likely to be in soup. Always, if you are not having a central line, use it from a fresh cannula, never from a available peripheral cannula. It has to be a fresh cannula or a central line. Okay, now come back to this patient. At 12 weeks, he presented like this. What do you think this patient has got now? Is it a recurrence of tumor? Is it something else? Is it a drug side effect? Or has he got some other rare problem which is unrelated to the drug or the cancer?
Sir, both of them cause VOD, sir. Veno-occlusive.
Not both, only one.
Sir, actinomycins.
Very good. Actinomycin D can cause VOD. Very good. How will you diagnose VOD?
Sir, clinical suspicion, sir.
Very good. It's a clinical diagnosis. It is a clinical diagnosis. Okay. You don't have any robust biomarker or a robust finding. It's basically a clinical diagnosis. How do you treat it? Treatment of VOD, you must have done it in the transplant setting.
Yes, sir.
How do you treat it? Any drug? Name one drug that you can use for VOD.
Sir, UDCA or
Okay. What else?
Defibrotide.
Defibrotide.
Yes,
Okay.
sir.
But I will also give a word of caution that a bad VOD, a true VOD, sometimes is very difficult to reverse even with defibrotide. The bad ones are very difficult. It's a very bad side effect to get. And if somebody gets it, it is terrible. We can go to the next slide. Okay, so defibrotide, you can do an ultrasound Doppler and look for the portal vein flow. That's okay. Next slide. Okay, so let's have some MCQ type of questions now, which Dr. Nandakumar has prepared. Here you have the condition on the left side of your screen, and on the right side are some treatment regimens. Do you want to match some of these? And even if you don't know, it really doesn't matter, but if you will know them, it will be good.
Sir,
because
sir, I am not sure about clear cell sarcoma. So metastatic will be DD4A, metastatic Wilms.
Okay.
And diffuse anaplasia is that UH. I'm not sure, sir.
Okay. It's okay. Even if you don't know, I'm not that bothered that you have to know all this. Come to the next slide. Okay. So basically, the bilateral Wilms, the point that was brought by Dr. Nandakumar is you have to use 3 drugs. Okay. So it is vincristine, actinomycin D, and doxorubicin. It is always 3 drugs. Even if it is early stage or early small size in both the kidneys. So you use 3 drugs. In metastatic, you have DD4A. Diffuse anaplasia becomes the bad one. So you again have multiple drugs. And in the CCSK, again, you have drugs which besides vincristine, doxo, you have cyclo and etoposide as well. Anything very specific about CCSK? What age group it happens and what is very specific about CCSK?
Sir, I don't know. In fact, I wanted to ask if why is it considered with Wilms tumor, sir? I have no idea.
So it is not Wilms tumor. It is not Wilms tumor, but it comes in other renal tumors which are studied along with Wilms tumor. It happens in slightly older age group than the typical Wilms tumor, and it has a predilection to go to the bones. You have another renal tumor, which is the rhabdoid tumor. That can happen in smaller infants, and it has a predilection to go to the brain and the bones. There was a question in the chat box, can we give NACT to a Wilms tumor without biopsy? What is your answer to that chat box question? And then I will give my views on that.
Sir, we can give, sir, that Europeans use chemotherapy before
Okay,
surgery. So I read
so
somewhere.
you can give. So you can
Yes,
give.
sir.
But
Yes.
I will you will have to give a qualified answer to this statement. You can give NACT to a renal tumor if the tumor occurs in the typical age group, which implies that, say, for example, there was a renal tumor at the age of 6 or 7 or 8 years old. I would not give without biopsy because the chance of finding it other than Wilms becomes much higher. Okay, so the chance that it is Wilms tumor at a typical age of 2 or 3 years is way, I mean, you are likely to be more than 90% right. But at the age of 7 or 8 years, you are likely to be wrong. And hence, you do a sampling if the age is older before you proceed for NACT. Otherwise, your answer is correct that you can proceed for NACT without a formal biopsy. Okay, Rashmi, I want you to tell me some other tumors besides kidney tumor where you can give NACT without doing a biopsy.
Sir, germ cell tumors you can give, sir.
Very good. You can do in germ cell tumor. What else?
Sir, 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 in HCC we can do.
Very
If
good. HCC, if you were to use, because you can diagnose it based on
Yes.
radiology. What else?
uh,
So you have answered very good. You have answered germ cell tumor. You have answered HCC.
Hmm.
One more, which was discussed by Dr. Nandakumar as well. You can give it in retinoblastoma because that is also a clinical and a radiological diagnosis. Okay. Okay. You do not do a biopsy or FNAC to diagnose retinoblastoma. Okay. Next slide. Okay. Now, this is a 4-year-old child who was lost to who came in the long-term follow-up clinic with skin bruises and gum bleeds. His blood test revealed thrombocytopenia with a white cell count of 51,000. Mother has lost her previous medical record and remembers that this child was treated for a renal malignancy with radiation therapy 2 years back. You could see this as the only available record with her. This is the regimen that this patient got. What is the most likely abnormality this child has currently? And what do you think was the primary kidney tumor that he was treated for?
Sir, he was treated with for sir, I think he has some leukemia, sir.
Very good. So he has some leukemia. Very good. Now, if
And
you were to put all the things together, what kind of leukemia is he likely to have?
not sir, therapy related AML.
Very good. So he's likely to have therapy related AML. If it is therapy related AML, what is the likely causative drug from this multiple
Etoposide,
drugs?
sir.
Etoposide.
Etoposide.
Very good. And if it is etoposide, what is the likely gene or chromosome that is likely to be affected?
Sir, not sure, sir.
So if it is a etoposide induced secondary leukemia, likely it is the MLL gene that is affected, which is on chromosome 11. Okay. And the likely tumor that he was treated based on the regimen, it is likely to be CCSK, the clear cell sarcoma of the kidney, because that is where you use this vincristine doxo and this etoposide combination. Okay. Next slide. Okay, so we got all the answers. Okay, now we have the next slide before you. Okay, so you have an 18-month-old child, 10 kg, with high-risk hepatoblastoma. Pretext 3 with P plus E plus. I'm not going to explain all this, and that's not relevant for this conversation today. He was planned for super plateau, cisplatin alternating with carbo and doxo. Can you just calculate the amount of cisplatin that he's going to get in 24 hours just to waken up all the people?
2.6
into
into
10.
10 is 26.
Very good.
16.6 into 10 is 166.
Okay.
And 1 mg per kg per day will be 10 mg per kg per
Okay.
day for 2 days, sir.
Now you tell me, what is the vial size of carboplatin?
Sir, carboplatin comes in 150 and 450, sir.
Very good. I like that answer because people don't know the vial strengths, and I just don't like that from people. What is the strength of 6 mercaptopurine?
6 mg. Sir, 50 mg, sir.
Very good. Very good. Capsule etoposide,
Capsule etoposide is 50 mg, sir.
tablet cyclophosphamide.
Tablet cyclophosphamide is 50 mg, sir.
Good. Very good. Okay. We can go to the next slide. Next slide. Okay. So this is a 5-year-old high-risk hepatoblastoma who was treated on Ciopal 4-HR protocol with dose 10 cisplatin. After week 3, his tympanogram on pure tone audiometry shows something which you are seeing on the right side of your screen. What is your interpretation of this?
Sir, to begin with, it looks like very poor. He has ear impairment in both the ears, sir, because he at and at sir, at 2000 it is only 60 decibels, sir, and there is a dip from 2000 in the right side and a significant steep dip from 2000 in the left side
That
also,
is
sir.
sufficient.
Bilateral.
That is sufficient. That is okay. I don't expect you to be an ENT expert, so it's okay. There is some problem in the ear where you expect that there is a high decibel frequency loss and the patient has ototoxicity of some sort. I am okay with that interpretation, and it seems to be more based on this. I will accept that answer. Now, my question to you is, what in adult and children, when you use cisplatin, what are the side effects that are unique to children and what are unique to adults? So, what are the common side effects and what are unique side effects? So, common is what?
Sir, common is nephrotoxicity, cisplatin induced significant one is nephrotoxicity,
Okay.
and then ototoxicity.
No, that is where it is different.
Okay,
In
sir.
adults, you will hardly see ototoxicity. That is not common. In children, and specifically smaller children, ototoxicity is a predominant problem. But in adults, it is the neurotoxicity that becomes as a predominant problem. So that is a difference. They are emetogenic, that is common to both adult and children. They are nephrotoxic, that is common to both adult and children. Auto for younger, smaller children. That is why you have so much emphasis on ear. I am sure that you don't give too much emphasis on ototoxicity in adults.
No,
It
no,
is
sir.
not, because it's not the predominant toxicity. It is your neurotoxicity. And this becomes a bigger problem when you use it in brain tumors because you also give brain radiation. So, radiation, smaller child, brain tumor, chance of ototoxicity higher. And also, not only is it higher, the impact with radiation and the neurological impairment that a brain tumor may have, the effect on the child becomes even more profound. And when you combine cis and carbo has some ototoxicity, some, not much. But the addition of cis plus carbo, it is not a direct addition. It is actually little bit more than addition. So those are the high risk features for ototoxicity. Okay. Now, is there any drug that you can use to prevent this toxicity?
I don't know, sir.
I will also give you a hint. This drug is also used in cyanide poisoning. Does it ring a bell now? Abhi bhi nahi. Chalo. It is sodium thiosulfate. So there is a trial. I want each one of you to read this trial, which was published in New England Journal of Medicine. I think in the year 2017 or 18, by Penelope Broke, on the in whose name you have this Broke toxicity of ear. So see the impact on ototoxicity with that addition of that drug. Sodium thiosulfate, which is also used in cyanide poisoning. Next slide. You can go to the next slide. We have talked about it. Okay. Okay, so you have an MCQ here now.
Yes, sir.
Which of the following statements regarding hepatoblastoma are true? Standard risk hepatoblastoma is treated with single agent platin at 80 mg per meter square. True or false?
So it is true, sir.
Okay. Vincristine and 5-FU are used by the COG in the treatment of hepatoblastoma. True or false?
Sir, I don't no idea, sir.
Well, it is true. It's okay. Even if you don't know, it's okay. It's true. Superplado backbone involves alternating cycles of cisplatinum and cisplatinum doxo. It
Sir,
will tell you.
cisplatin and carbodoxa, sir.
Oh,
Not,
very
it
good.
is false.
So you were awake during the lecture. Good. So that lecture was good. Daily dose of carboplatin is based on weight, height, and EGFR.
No, that I don't know, sir. If it
So
is
there was a complicated figure that
Yes, sir.
was shown by Dr. Nandakumar. Next slide. So that last statement is also false. So the first two are true and the last two are false. Okay, we can go to the next slide. An 8-year-old boy presents with headache, vomiting, ataxia, and head tilt for 2 weeks. Neuroimaging revealed a well-circumscribed 4 centimeter into 4 centimeter tumor in the vermis. He underwent suboccipital craniotomy and with the resection. The patient underwent MRI 3 weeks post-op, which revealed some residual tumor. MRI of the spine demonstrated 2 focal enhancing nodules in the cervical and thoracic spine. CSF was positive for malignant cells. HPR was group 3 medulloblastoma with c-MYC amplification. Based on whatever is stated here, is it a good or a bad medulloblastoma?
It's a bad one, sir.
It's a bad one. It's a bad one. Okay. I mean, I expect that the resident can always look in the book what group it is, what thing, but it's a bad one. It's not good one. It's bad one. How will you manage this patient?
Sir, RT to the primary with craniospinal irradiation and chemo. Not
Okay.
sure.
Okay. Chemotherapy. You will give chemo and you will give radiotherapy.
Yes, sir.
And
Yes, sir.
I want to understand, in the radiotherapy, will you use some radiosensitizer?
Sir,
And
we
who
will
is
use, as sir mentioned, sir, carboplatin we can use, sir.
Yes, and I believe that your hospital is also using
Yes, sir.
that particular protocol. Although I will also confess that it is again one of the options. It is not the only option because this analysis came in the subgroup. It was not a targeted analysis for this very topic. It just came as a subgroup. But it is okay to know that yes, carboplatin radiosensitization has been used. If you go to the olden studies of cervical cancer, carboplatin was used and as a radiosensitizer in cervix cancer also earlier. So just for your awareness, tell me the drugs that would be used for medulloblastoma, the name of the drugs.
Sir, vincristine, cyclophosphamide,
Okay.
and I'm not
Uh-huh.
sure. Cisplatin.
See, you are unlikely to go wrong in any solid tumor if you say cisplatin. Okay, cisplatin is used from head to toe in every single cancer. Go from top: brain tumors, head and neck tumors, tumors in the chest, lung, GI tumors,
Bladder.
urinary bladder, germ cell tumors, osteosarcoma. So if you know cisplatin, you are unlikely to go wrong because it is used in almost every solid tumor that is there. Now my question to you is, instead of cyclophosphamide, okay, let me ask you one thing. The drugs that you said, what is the frequency or interval between cycles?
3 weekly.
Very good. Now, in the slides that were shown by Dr. Nandakumar, he also said you can probably, or maybe he said, or he brought out or not, he brought out a drug CCNU is also used in medulloblastoma. So what is the interval of cycles when you use CCNU? Is it weekly? Is it 2 weekly? Is it 3 weekly? Is it 4 weekly? Is it 6 weekly? Is it 8 weekly? Is it once in 6 months or what?
Sir, I'm not sure, sir. Weekly.
Okay.
I'm not sure.
Okay, CCNU is what? Is it a infusion, tablet, what?
CCNU is a tablet, sir.
Very good. What is the strength?
Strength, it comes in, sir.
Since we are talking of drugs, it is a drug.
Yes, sir. Yes, sir.
And so what is the strength? It is a 40 mg.
40 mg.
Okay, so don't write a prescription of 50 mg CCNU. Okay, be careful in what way. So CCNU, I asked this question because CCNU comes with a late nadir and a late recovery. So the cycle is every 6 weekly. So if you replace cyclophosphamide with CCNU, the interval is 6 weekly and not 3 weekly. Okay? Tell me name some other drugs where the interval is beyond 3 weeks with some of the chemotherapy drugs.
Sir, liposomal doxorubicin is 28 days.
Okay.
And
okay.
6.
There is one drug which is used in low-grade lymphomas. Tell me now, I've given you a hint.
Sir. Rituximab and bendamustine, sir.
Very good. So bendamustine. Okay, bendamustine. One more drug which is used in brain tumors also, and sometimes in melanoma also.
Sir, cistemozolomide, sir.
Huh?
Temozolomide and cisplatin.
Temozolomide, not cisplatin.
Okay.
Temozolomide. Okay, so temozolomide also has a late. Since we are talking about drugs and we are talking about the timing of neutropenia, tell me, when you use, what is the difference between docetaxel induced neutropenia and cyclophosphamide induced neutropenia? Both these drugs you will use in breast cancer also. You will use sometimes.
Yes, sir.
So you use docetaxel in relapse setting of hepatoblastoma. Okay, just for information.
Okay.
When does neutropenia happen with docetaxel?
Sir, not sure, but later than cyclophosphamide.
No. That is the question. If you get a lady with breast cancer or a child with hepatoblastoma who has fever on day 4 of docetaxel, be more vigilant, because in cyclophosphamide the neutropenia will happen around day 8, but in docetaxel it will happen earlier, around day 5. So if the lady comes on day 4 or 5 with fever, even if the count is not low, be sure that on next day it is going to drop. Likewise in hepatoblastoma. So it has early onset neutropenia, unlike cyclophosphamide. So please have a list of drugs which have late onset and early onset neutropenia. Very good. We can go to the... Actually, one more question. Cisplatin. What line of myelosuppression does it affect primarily?
Sir, platelets.
Red cells.
Sorry.
Okay, platelet is carboplatin. Next slide. Tell me when I have to stop. How many minutes more we have?
I think we are running.
have time till 4.
Okay, so I can take another 5 minutes. Okay, a 15-month-old presented with this picture that you can see here. What's your management plan? Is it early stage or it looks advanced stage to you? Tell me, what is the likely tumor?
Sir, it is advanced stage, sir.
So it looks advanced. And what stage you want to put it in?
Sir, it is intraorbital, extraocular, sir. So it will be stage.
Yes. Tell me.
Stage 3, sir.
Very good. Stage 3. Next slide. So what's your management plan?
Sir, management would be, sir, neoadjuvant, followed by enucleation, followed by adjuvant.
and radiotherapy.
And
Okay, you will give radiotherapy as well in stage 3 retinoblastoma. So here we discussed about milligram per kg, and we discussed about the question
Yes.
of per meter square area. So please be very clear, in infants, if you have a milligram per meter square dose, do not give full dose in infants. Otherwise, you will land up in problems. You always reduce the dose by 50%, or you use a milligram per kg dose. Okay. Okay. Let's try and answer this MCQ. A 1-year-old infant presented with leukocoria, examination under anesthesia shows it's a group BRB in the right eye and group BRB in the left eye. There was no family history of retinoblastoma. Identify the true statement, true or false. Left eye local therapy with enucleation of right eye, true or false?
Sir, false, sir. It will be
False.
under treatment.
Okay. Upfront enucleation of right eye followed by CEV for 6 cycles and local therapy to left eye.
I'm not sure. Could be true, sir.
It is true. It is perfectly fine. You will do upfront enucleation of right eye because it is group E. You will give chemotherapy 6 cycles because you also have a group BRB. Which group retinoblastoma you can treat without chemotherapy?
Sir, stage 1.
No. Stage 1 is a classific. No. Group A.
Group A. Okay, sir.
Okay, group A. Okay. When you use the word stage, that is an oncological classification. For intraocular, for an ophthalmologist, it is group A, B, C, D, E. Okay. Stage 1, 2, 3, 4, which is IRSS staging, is for oncologists. Okay. Neoadjuvant chemotherapy with CEV 2 cycles followed by EUA and enucleation of right eye plus local therapy to left eye. Is it right or wrong?
Yes, sir.
So both 2 and 3 are right. You can also give chemotherapy first and then enucleate, because in any case you are going to give 6 cycles to this patient. So you can, this also gives some, because sometimes the patient may be hesitant for upfront enucleation. It gives time for the family to adapt. Okay. Enucleation plus EBRT to the right eye followed by ECV therapy for 6 cycles.
Sir, left eye is not addressed in this, sir.
Okay. What about the EBRT?
Sir, so EBRT should be given. I don't know if it is to be given before chemo or after chemo, sir.
No. You do not give radiotherapy. Your indications for radiotherapy are only stage 3, or if you enucleate and the cut end of optic nerve is positive, or there is extrascleral involvement. As a routine, radiotherapy is not given. Okay. Okay, next slide. Next. Okay. Blinatumab, mechanism of action, probably you know. How will you, okay, how do you administer this drug? Tell me.
Sir,
Is it given as an IV push, IV over 1 hour, IV over 5 hours, or something else?
sir, it is given continuous infusion, sir, over 24 hours.
For how many days?
Sir, 28 days and then 14 days gap, sir.
Okay, good. So it is given as a continuous infusion. And what are the side effects that you will observe with this?
Sir, myelosuppression and
Minor.
CRS.
CRS, very good. So
Arrhythmias.
Practically what you would see in CAR T cells, something like that, but to a lower extent. You can get CRS, you can get neurotoxicity, and it is primarily in the first few days. So you admit the patient for the first 7 days, and then you can discharge the patient on a pump. Okay, and there is a specific way of making blinatumab. There is a specific dilute that you get. You dilute first in that, and in the saline you will add another solution which is there in the pack. Okay, so there is a specific way of giving the drug, not just like that. It's not that you just take it and dissolve it. Okay, I'm not discussing that further, but you must be aware that it's a very specific drug. Next slide. Next slide. Okay, inotuzumab. How would you give this drug? How is this drug given differently from the previous one? What is the vial size of this inotuzumab? Oh, it is written here. You have to be
1
smart
mg,
enough.
sir. 1 mg, sir.
It is
1
written
mg.
here. Yes. What was the vial size of the blinatumab?
It was 38.5, sir.
It actually, if the actual strength is 35
Okay, sir.
in that 35 micro and 35. Okay. How do you give inotuzumab?
So, inotuzumab is given like normal infusion, sir. There is
Okay.
no with NS diluent as normal saline.
Okay. Side effects?
So, side effects is like same, sir. Myelosuppression and sir, VOD, sir.
VOD happens when? During infusion of this or something else?
I'm not sure, sir.
So basically, inotuzumab increases, it can per se cause this VOD, but the real risk is that when you basically you are going to take the patient for transplant.
Yes, sir.
So the risk of transplant induced VOD becomes much more if you have given VOD within the last few days or weeks. That's why you want to wait a little bit after inotuzumab before going for transplant. Now, the problem is if you wait, then you also have the risk of relapse. So that is the catch 22 situation for you. Okay. Next slide. Next slide. You can go to the next slide. Okay. So here is a 12-year-old adolescent male who presents with fever, fatigue, and weight loss. He had cervical adenopathy with liver and spleen enlargement. His peripheral smear showed blasts and bone marrow flow was suggestive of B-ALL. His report was pH positive ALL. He was started on this BFM 95 protocol with imatinib. His bone marrow at the end of the induction showed the following. Where is the report? Can you have the next slide? Okay, here is the report. So you have MRD, which is 1.4%. Okay, what should be the MRD?
Sir, 0.01, sir.
Okay, less than 0.0.
Yes, sir.
Okay, very good.
Sir, it is MRD positive, sir.
So what do you want to do now?
Sir, sir, try for CR1 and transplant in CR1, sir.
Okay, next slide. Very good. So what option you want to choose from this?
Sir, B, sir, B, C, B and C, sir.
You can probably use B. I would probably go with B in this patient. Next slide. Okay, so that's the end. So I would, if the patient is MRD positive, then yes, probably you would like to use. Can we take some questions from the chat? There are some questions in the chat as well, right?
Yeah, I think you have already answered. So one question is proton RT safe in children with medulloblastoma? Yeah. So I will. Yeah. So that question, yeah, it's a very good question, considering that a lot of centers are coming up with proton RT. However, as of now, it is not recommended for young infants to use radiation therapy in medulloblastoma. The age cutoff of some of the CNS tumors, like rhabdoid tumors, have come down from 3 to 2 years and less, even with conventional RT. Feasibility studies in some patients, I think, have been done where very young infants have been given proton RT, and that has been given with limited toxicity. But apart from that, we do not have clear data to recommend proton RT for children with medulloblastoma. The standard of care still remains chemotherapy with high-dose chemotherapy consolidation. Sir, there's another question. Can you take this? How to go ahead with a patient of hepatoblastoma having persistent high AFP post-treatment and no radiological disease? It's a vexing problem.
Yeah. So this is a tough question, and actually so I would probably say so I would probably say that this patient probably needs this patient actually will relapse ultimately, and I would probably wait for the actual relapse to show up before I treat, because there are not very good options for relapse hepatoblastoma. So I would wait, and if it emerges, I would like to resect it and then give a salvage therapy. That would be my take on this.
Dr. Nandakumar, can you take this question? What is the ideal time?
I just wanted to add, so basically when you suspect relapse, you have a biochemical relapse, which is increase or not responding AFP values when you don't have a log fall. The other is when you have radiological evidence of disease, which could either be in the primary site in the liver or in the metastatic site, if you were to start with a metastatic disease. So first thing, you have to make sure that you do not have any of this. But if you have, the ideal treatment in hepatoblastoma is chemo followed by local control, which is surgery. So which point of time you identify this is very important. Suppose you have a rising AFP and your radiological lesions are still persistent, then, and if you've just completed 2 cycles, the best thing would be to go and surgically resect it, because local control is very, very important. Because you persistently give chemotherapy, you're going to induce resistant clones in such children. So if it is during the treatment or early phases of treatment, when you find an AFP fall, you can still go ahead with local treatment and then consolidate with your adjuvant chemotherapy. However, if it is in the later part, say you're coming to 4th cycle or 5th cycle, and then you're having an evidence of biochemical relapse, as sir rightly pointed out, you have to only wait, because ultimately he is going to have a relapse, which could either be in the local site or in a metastatic site, for which we have very limited salvage options. One such option is vincristine irinotecan, which is used in relapsed solid tumors, and however, the results are not very great with the relapsed hepatoblastoma. So the next question is, so which is the next question that I have to take?
Yeah, the ideal time of post-operative imaging, like MRI.
Okay, so ideal time for post-operative imaging, like MRI, brain, and spine. Okay, so 4 weeks is what we practically follow, and CSF we say at least wait for 2 weeks. The reason is when you have a surgery, you have a lot of post-operative changes, which involves a lot of proteins being positive in the CSF. So you might have, and some amount of drop meds do happen during the surgery, so which can get cleared automatically. So when you do an early CSF, you might falsely stage this child as high risk. So at least you wait for a minimum of 2 weeks at least. But most often, by the time the surgery completes and then the patient comes to the pediatric oncology, somehow takes 3 weeks, because you either have post-op issues either in the form of mutism or sometimes meningitis, which are very commonly seen in these children while treating brain tumors. And an MRI is ideally planned 4 weeks after the date of surgery, because you have to start your treatment at least by 28 to 31 days. If you start your RT to plan, etc., your outcomes are going to be better. So it is earlier the better. I know older protocols used to wait up to 6 weeks and out, but 4 weeks should be ideal.
Okay. I think now it's past 4. I will ask Dr. Vidit or Rapid.
Thank you so much, sir. Thank you so much.
2 minutes.
Samir sir, yes, please. We would need your final thoughts for today's session. I
Okay,
think it was a very interesting session, and you brought out the most important, in between lines, practicalities that residents miss out. Sir, your last word, sir.
Okay, thank you so much. I actually learned a lot just talking to all the residents and listening to Dr. Nandakumar. So it was my learning as well. I would just say that all the residents should be aware of, please go to your daycare, see how the drugs are being administered, because we have got so routine that the nurse will do it. Yes, likely they will do it right, but you should be aware, because after you pass out from wherever you're working, you may go to a center where you have to open your own daycare. So you should know how to guide the nurse or the treating team how to administer. Please be aware of the vial sizes. Please be aware of the tablet strengths, capsule sizes, so that you don't write absurd prescriptions of 40 milligram 6 mercaptopurine or 40 milligram of etoposide capsule based on the calculated dose. That's all I'll say. And I think it was a great session. Thank you so much.
Thank
And
you, sir.
Rashmi, you
Thank you
did
for
very
the
well.
Yes, sir. He's actually taken up a huge task of going through the drugs in pediatric oncology. It's a scarce source of that I mean medical oncologists usually don't treat a lot of pediatric tumors, and these sources are very scarce to learn how chemotherapy is done in pediatric, the body surface area, the cap of dosage, and especially the toxicity. So I think this lecture was beautifully done, both from the speaker, from our moderator, Dr. Reghu, who's been kind enough to take this, position, and sir, especially you. Thank you for taking out this time on a Sunday afternoon. Thank you so much, sir. Thank you.
Okay, bye-bye.
Bye-bye. I would like to introduce our next session to all our audience. And our next session is on radiosensitizers. So we'll be talking from head to toe what all radiosensitizer drugs we use along with the radiation. And we'll be focusing mainly on the mechanisms that bring out these, uniqueness of these drugs. And for that, we have Dr. Chetan Deshmukh, sir, who is a consultant from Pune. And our moderator is Dr. Rajan Yadav, sir. And our speaker is the very young, dynamic Dr. K. Meena. So we'll see you on next Sunday. That will be our last for this series. And then we'll try to make another season for all the residents next year. So with that, thank you so much and good evening.
Bye-bye. Bye-bye.
Bye, sir.
Thank you, one and all. Thank you.